Men who receive their treatment for prostate cancer are told on their first visit, this is going to impact your sexual function. And women aren't told that always. And then the symptoms come up and they Google it like everybody does. And when you Google like sexual problems or sexual dysfunction, it's like all Google images, it's all about erectile dysfunction. And that's I think where we can do a lot better.
Welcome to the Fempower Health Podcast, helping you become the CEO of your health. I'm Georgie Kovacs, your host. It's Cancer Awareness Month, and one of the topics many either don't know about or are scared to talk about or don't even know how to talk about it is your sexual health while undergoing cancer treatments. And we are here to get real and to provide the support that you deserve and need. Enter Dr. Kristin Rojas. She is a Society of Surgical Oncology fellowship-trained breast surgical oncologist and gynecologic surgeon with a passion for comprehensive wellness in women's cancer care. And she definitely has a passion for helping you with your sexual health. This episode completely blew me away. I did research in advance and definitely did not find the nuances of the helpful information that she discusses. And so I'm just going to stop with any more introductions and let you listen to the amazing information she has to share. And I promise you will get so much out of this and feel a lot more empowered about getting back your sexual health or preparing for some of the things you may be dealing with before, during, and after your cancer treatments. To be honest with you, I'd never really considered how sexual health changes when you have cancer. I mean, my mom had cancer. She passed away from it. I mean, I guess we didn't really talk about our sex lives, but I mean, it's just something that I was never really aware of. And so I really appreciate that being educated today around what patients really need to be considering and expecting. So before we dive into the topic, why don't you talk to us about your background and specialty and kind of how this has become a passionate topic for you?
Sure. Well, first of all, thank you so much for having me. And I'm thrilled to be here with you for this podcast. I think it's such an important topic, but my name is Kristin Rojas. I'm a breast cancer surgeon, but I actually started my career as a gynecologist. So I wear kind of two hats. I'm a board certified gynecologist and a fellowship trained breast surgeon. So I always knew I wanted to have a career in women's health. And I did my residency at Brown University in OBGYN, and they had a unique program there where the GYN residents actually were involved in the care of breast cancer patients as opposed to general surgery residents. So I did a fellowship in breast surgical oncology or breast cancer surgery, and then was in New York for several years as faculty at a big hospital in Brooklyn. And because I started out as a gynecologist, I don't know if I was asking the question or if patients knew that about me and they were more likely to bring these topics up. But I started to realize how incredibly common this was. And just like you, it was something that I hadn't really thought about. But when you ask the question and looking at the literature, more than 80% of women, specifically breast cancer patients, report sexual side effects from treatment. And so I started this program called MUSIC, stands for Menopause, Urogenital, Sexual Health and Intimacy Clinic. And I made it a benign sounding acronym because my patients are of all ages and not everyone wants to be referred to sexual health clinic. And so the MUSIC program is for women with a history of any type of cancer who are experiencing sexual dysfunction. Through this process, I've learned a lot about how other cancer treatments at other disease sites, such as leukemia, lymphoma, other GYN cancers, sarcoma, all of those treatments can impact sexual function, young women, postmenopausal women, and it's an under discussed topic. And so my goal is to make it normal conversation. So thank you so much for having me so we can do that.
If someone is about to undergo cancer treatment, like what could they expect around sexual health? And I ask this because one of the things that's really been fascinating to me as I've interviewed so many guests on this episode, I think it's like over 60 experts now, maybe over 70, is there's so many nuances here, right? Like when you were talking about the phases of life, like there's phases of life too that impact our sexual health. And so, here I think it's very obvious you're getting cancer treatment. There's probably a direct impact. But you were definitely speaking specifically to the side effects of the medications. And so I guess, I'd love to know what is impacted here. Like what should women expect and what might be surprising to us to hear about this?
Outside of the psychosocial impact of a cancer diagnosis, which is a huge hit to a woman and her caregivers or her partner, her family, there actually are these biological consequences of cancer treatment that really almost mirror the effects of a normal menopause. And as a society, I think we don't do a great job preparing women without cancer for menopause. It's not something we all talk about until it's your problem, and then you quietly ask your friend if they're experiencing the same symptoms. Well, we're putting younger women into menopause, and then women who've already gone through menopause worsening their symptoms. And the way that works is it's not just women with a history of breast cancer, which now that we're raising awareness about this seems to be what everyone kind of focuses on, but it's women with a history of any type of cancer who receive chemotherapy. Chemotherapy basically shuts your ovaries down. So your ovaries are what makes estrogen, and your body before menopause is used to having normal fluctuations in estrogen, and that's what causes, monthly cycles. Well, when you drop those levels of estrogen really low, it affects not only your brain, but your heart, your bones, and then the vulva and the vagina. And so the symptoms you most immediately experience are hot flashes, because it's literally like a drug withdrawal from estrogen, which does a lot of good things in your body. Then secondary effects that you usually feel shortly after are vaginal dryness, which usually manifests as painful sex. So oftentimes with this big psychological hit of a diagnosis, women are kind of putting their intimate lives on the back burner while they focus on getting through treatment, getting through surgery, getting through radiation. They may go back to try to have sex after all those acute issues are resolved, and they'll realize, oh my gosh, like the biggest symptom patients report when they see me in the program is all of a sudden I went back to having sex and it felt like knives, and it was so scary. No one told me that was going to happen. And and patients can have bleeding after sex, which is very traumatizing. They don't feel like themselves. Their desire is much lower. And all of these things can impact not only it, you can have sexual dysfunction without even being partnered. And obviously it doesn't, isn't specific to a sexual orientation or gender, but my program does focus on women. So it can affect women biologically as well as the psychosocial impact. There's also radiation, which comes into play. A lot of women who have GYN malignancies get pelvic radiation, and that basically shuts down their ovaries and can make the vagina shorter or narrower, making penetrative intercourse impossible. And so there's some interventions that we have during treatment to help prevent those sequelae, but oftentimes we're just trying to throw so much information at patients and get them through this multi-step process that is cancer treatment that we don't always do a great job addressing those issues and mitigate and giving them mitigation strategies. So that's kind of why I like to bring it up, because it's like, as you said, you have a healthcare background and you talk to all these experts, but even you hadn't really thought about it that much. And it's true, even from the world of gynecology, a lot of GYNs don't think about it that much. And so that's my goal, is to raise awareness about the problem, because it's actually extremely common.
Wow. So tell us, like in an ideal world, or maybe you can compare like what typically happens, right? And what an ideal world should look like. Because like, for example, I've done a lot of interviews around the pelvic floor. And what was really interesting is a tip that one of the experts gave, which is while you're pregnant, go see a pelvic floor physical therapist before you deliver, because we can look at your body and your muscles and your pelvic floor and see what are the best positions for you to deliver your baby, to create the least amount of injuries to your body. And it's one visit. So what would be the equivalent of that, of like what actually happened? Because I'm honestly envisioning cancer diagnosis, book your appointment, go get your chemo or radiation. Like that's what I envision the world is. And you're nodding, so I'm assuming yes.
Yeah, I think it's really tough because, as a breast surgeon, I'm often the first person that the patient sees when they're newly diagnosed with breast cancer. So I've got to get through what this diagnosis is, what your prognosis is, and what the steps are of your treatment, get you on board with everything in less than an hour, and start the process. And so that is a lot. And some places get even less time than I do. I'm fortunate to be at a big center where we have a big team. So I really feel like I get to spend almost an hour with every new patient, but I know that's not the case in a lot of places because of the nature of our healthcare system. So I think that one way is to have a team where there's someone else who's kind of in charge of taking over this, that reaches out to the patient after first information has been digested and kind of talks about all the other aspects of support through treatment. But it's interesting because there's been studies looking at this. Men who receive their treatment for prostate cancer are told on their first visit, this is going to impact your sexual function. And women aren't told that always. And then the symptoms come up and they Google it like everybody does. And when you Google like sexual problems or sexual dysfunction, it's like all Google images, it's all about erectile dysfunction. And that's I think where we can do a lot better. And so I think, it's a lot to put on the primary provider who sees them first and tries to get them through the cancer treatment part. But I think it's really great if offices can have someone who kind of follows up with the patient after, if it's not mentioned at the first visit, because oftentimes it's very overwhelming and it's hard for patients to really digest everything we're giving them at that first visit.
Can I ask you a question that it triggered when you said the first visit after someone is diagnosed is with me and you're a breast surgeon. So can I just clarify a nuance? Because since I have you, like a lot of people will say, well, surgeons, we know what they want to do. They're trained to cut people open. So can you just, for someone, because I think this is, even broader, it's like, yes, we want to get into sexual health, but I kind of almost want to get into like, how do you ideally manage the fact that your body is going to, so it's not just, let's make sure the cancer doesn't get worse and we can, get rid of it and keep you alive and keep you healthy. And we're going to specifically dive into sexual health. But I do think there's a couple nuances. If you don't mind, I'd love to ask.
Oh.
I would assume it's an OBGYN they're visiting, they get their, annual exam, and then there's a potential, concern or diagnosis. Is it literally typically the next step is a surgeon? And then is the surgeon like, the title is, okay, in there, I also do radiation, and it's not just I go straight to surgery. So how does all that work with the nuances of the specialists?
No, I love that you asked this because it's really important. So usually what happens is a patient will be getting an annual mammogram that's ordered, or annual breast imaging, or they'll feel something that they usually bring to like their primary care provider or their GYN. They'll start the process for the workup to get the diagnosis, which usually leads to an image-guided biopsy. Once they get that biopsy and they get the results, then patients are referred to one of the members of what we call a multidisciplinary team that takes care of breast cancer. So like 20, 30 years ago, you would see a lot more surgeons and oncologists kind of as siloed and standalone. That model still exists in a lot of places and it's a fine model, but now we move more towards disease site specific teams. So a team for breast cancer, a team for pancreatic cancer, a team for colorectal cancer in a lot of bigger cities. It's not always the case in rural areas, and that's okay. But for a lot of the times, patients are referred to like a cancer center, or they'll be referred to a surgeon who's also a breast surgeon who specializes in breast cancer. Even though like I love to operate and that's my job, a big, now with all of these targeted therapies, it's doing a patient a disservice for me to just take them to the OR immediately and not make sure that they don't need something else first. Because a lot of times patients, especially younger patients with more advanced disease, really benefit from targeted treatment before we go to the operating room. And so that's why working as a team, and in a lot of big centers, every new patient or almost every new patient gets discussed as a team to figure out not only the right treatments for them, but the right order of treatments. And so I think of the breast surgeon as kind of like the quarterback of the team that kind of decides what's the next step. Either we go to the OR or no, I need you to see my colleague first, but keep tabs on you through this process, and then you'll come back to me after the first phase. And so sometimes patients are referred to a breast surgeon, or sometimes they're referred to the medical oncologist, and that's why it's important that we're always communicating. So to answer your question, yes, my job is as a surgeon to remove the cancer, but I think today it's a lot more nuanced than that, because every woman's cancer is so different, and it's the treatment of breast cancer is evolving so quickly.
In the smaller cities where we don't have the opportunity for teams, I mean, I don't know how much you can speak to that, because that's something I've become really interested in. And, I think season 3 of this podcast is really going to be diving into what can everyone do, because I tell you, I've been getting frustrated. I feel like all these solutions are for people that have really, really good health insurance and a ton of spare cash. I cannot ignore it. And so even if, I feel like everyone has even like one little tip for people who may not live, in one of the metropolitan areas of the United States. So how does it work there, and anything someone should consider? Because I think, it's not like we all plan and are experts in cancer once we get it. What are some quick things that people should be aware of in their treatment plan?
So this is a great question. And my father is actually a general surgeon in rural Texas. And
there you go. Perfect.
Yeah. He was in private practice for a long time treating women with breast cancer. So I've definitely been able to see how that works as well. And in that setting, I think patients are often referred to the breast surgeon first. And I think important questions to ask your breast surgeon are, okay, who else am I going to be referred to? Because really nowhere is breast surgery the only part of your treatment now. It's just a matter of, in a rural area, you may be charged with coordinating your own care kind of, and asking, usually surgeons that are in a private practice or in the community have people that they reach out to and refer you to. So I think a good question to ask is, who else is going to be involved in my care? Who do you recommend? And at what step in the process is surgery? Because sometimes it's first and sometimes it's second.
The bigger centers tend to have like these patient care teams where it's like you mentioned earlier, they're like calling and checking in. And I know this is where like they're the folks kind of assigned around things like fertility preservation, and hopefully, more and more people will be assigned the sexual health proactive discussions and things like that. So I think it's important for people to be aware there are these roles that exist, but they may not exist everywhere. So it's really up to us as patients to be aware and be able to ask the question, which is so hard, because it's like, how do you keep track of all the things you're supposed to be asking? Because you never know what kind of health issue you may come up with.
Well, that's actually why I have a social media account that's breast cancer focused. And then I also have one that's related to the Sexual Health After Cancer program. Is I'm big on patient education for patients everywhere. So I'd really encourage patients to find advocacy groups. There's a lot of, depending on your type of cancer, there's a lot of advocacy groups out there that have whole websites dedicated to patient education and what to ask your doctor when you go see them. There are people out there that are really trying to disseminate this information and making it much more accessible than it was even a couple of years ago. So while it is nice to have someone in your office who's kind of charged with that, sometimes that is kind of on the patient in certain situations. But I tell patients, you end up having a PhD, a personal history of the disease, and their patients come in from all walks of life, and they're so well informed. They've looked up everything. They know about me and where I trained. Everyone can look that up. And so I think that, now information is a lot more accessible, but I'd really encourage patients to look up some of the big advocacy groups for breast cancer. And those include Rethink Breast Cancer, which is a group targeted towards younger women with breast cancer. There's the Breasties. There's Boarding for Breast Cancer. There's all these groups that really focus on patient education and helping women through this process. Oh, and then when women are looking for options for reconstruction, one of my, someone I met who I really like and think is a huge advocate, her name is Terry, and she has a site called Deep Sea Foundation, or Deep Sea Journey, DIEPC Journey, which is a type of reconstruction flap. It offers a lot of education. So,
oh wow, thank you.
Yeah.
Because I do have show notes, and all the stuff we discuss here, I'll have links to, so people can refer to it. So thanks for sharing that. And I'll also put your Instagram accounts on there too, because, and I like that you brought up advocacy groups, because, when I look for people to interview, sometimes people email me questions about topics, or a friend will call and I'm like, oh my gosh, I need to do an episode on this. And if I don't already know someone, I either
go to a previous expert I know and say, who do you know? Like my orgasm episode was based on a previous sexual health person. I'm like, I need to know who to talk to about orgasms. My friend asked me a question. I had 0 answers for her. And that's how that one came to life. But if I don't have that, then I truly go to the advocacy groups and I research which ones have scientific evidence, which ones have doctors and patients on board. Because if it's just doctors or just patients, I feel like it's not as balanced. So I really look for that kind of criteria. So now let's talk about more around how you're handling the sexual health part of it and, what your program is designed to do and kind of how it works. Because I think from that, we can learn a lot and I can ask you some more questions based on what you share.
Sure. Well, the first visit is, I take a history looking at, what type of cancer the patient has and what are their most bothersome symptoms, what's really impacting their life. And I think the exam, I'm fortunate that I have this GYN background so that I can do a GYN exam and kind of get a lot more details about why they're experiencing pain or what may be the clue, like what clues we could figure out to fix their problem. But even in places that don't have someone like me, you can still start to address these symptoms even without a very detailed pelvic exam. My program is, I tell patients to keep their regular gynecologist and think of this as like a super subspecialized visit. And I often coordinate with their gynecologist and see them a couple times and then can send them back. But the most common symptoms in the program are painful sex, which is the first manifestation of vaginal dryness that patients usually feel, and then low desire. Those are like the biggest concerns. For vaginal dryness, it's actually not that complicated. I really have like 3 or 4 steps, and a lot of the program is education. When the estrogen goes really low in the tissues of the vulva and the vagina, the vulva being the outside and the vagina being the muscular tube of the inside, they become very delicate and less stretchy, a little bit thinner, and they're much more likely to be irritated by long-named chemicals, artificial fragrances, and things that we don't even think about, like fragrances in the detergent that we wash our underwear with, or sitting in bubble bath for a long time. All of those things can start this cycle of inflammation that just makes sex painful or dryness worse, or this feeling of burning and irritation all the time. So the first step is to eliminate irritants. Be really cautious about what touches the area, and reading labels, avoiding things with preservatives, any artificial fragrances. And then the second thing is start a moisturization regimen. So just like we use under eye cream and put on a moisturizer every night, start thinking about moisturizing the vulva and the vagina at least 3 times a week. And whereas in the past, there was like one brand name moisturizer we would tell everyone to get, which is like over the counter at the grocery store, but we actually have way better products now that have really high tech formulations that don't even necessarily have hormones. Because a lot of women, breast cancer patients with a history of estrogen receptor positive breast cancer, so hormone sensitive breast cancer, we typically try to avoid estrogen products, although sometimes we do need to use them. But a lot of women with other cancer types like cervical, colorectal, lung, sarcoma can all use hormone medications. And so non-hormonal moisturizers, the ones I tell patients to look for, have hyaluronic acid. So the same molecule that's in like eye cream that pulls moisture from the environment, holds it on the skin. There's vaginal moisturizers with hyaluronic acid in the form of suppositories or gels. And starting that like 3 times a week can make a huge difference. So I separate moisturizers, think of moisturizers for maintenance, and then lubricants for sexual activity, because oftentimes patients don't know how to use which one. Like they'll maybe using the lubricant for a moisturizer, and they work in different ways. So for lubricants, you want to find one that doesn't have any gimmicks. So no like warming sensations. For my patients with a history of cancer where those tissues are just really sensitive, no flavors, anything like that, really basic. And I encourage them to try a silicone-based lubricant that doesn't have fragrances or preservatives. There's a couple of brands that I like. Some brands that for moisturizers that I recommend are the Bonafide suppositories called Reverie. Good Clean Love makes a good hyaluronic acid moisturizer called BioNourish. And then there's Hyalogyne. It's also a hyaluronic acid moisturizer. For lubricants, I tell patients about Uberlube. It's a silicone-based lubricant that has no preservatives and is super slippery and really minimally doesn't irritate anyone. Whereas a lot of like over-the-counter grocery store lubricants can really irritate patients because they have a lot of chemicals in them. So I empower patients to be the ones that pick the lubricant, because a lot of times that's put on the partner and the partner just shows up with, whatever is at the grocery store. And
Right.
so, yeah. And then lastly is, that's talking about dryness and improving the stretchiness of the vagina, decreasing infections, irritation. But lastly is the pelvic floor. And I'm glad you really brought that up, because oftentimes I recommend patients see a pelvic health physical therapist. They're amazing. They're so awesome. And a lot of them have there's a lot of good social media accounts from pelvic health physical therapists. And so I encourage everyone to find one, if you don't have one in your area. But they really help patients focus on relaxing the pelvic floor muscles, because, patients, by the time they get to me, they've gotten all kinds of crazy advice. Like one of them being like, oh, you just need to do more Kegels. Well, Kegels actually aren't what these patients need, because the pelvis is like a basket of these muscles woven together. When you start to feel pain with sex, you start having spasms in these muscles unconsciously, and it just starts this negative feedback loop. What we need to train these patients to do is be able to relax those muscles. But it's hard if sex has been painful for a while. They have this anticipatory anxiety where they're nervous and tense, and it's hard to really get them to relax those muscles. So sometimes having a coach like a pelvic health physical therapist is really helpful. Some patients are really more comfortable with taking on are better at taking these cues, and don't if I can't get them into a pelvic health PT because of insurance, I can kind of coach them through how to do this. And I can give them a dilator, which is helpful for training them to relax the muscles, use the dilator in a non-threatening situation, help stretch out the tissues of the vagina to make sex less painful. And then one last thing I'd like to mention is a device called the O-Nut. It was actually invented by a woman, I believe this is the story, who had really bad endometriosis. And so those patients often have pain with deep penetration with sexual activity. And so it's literally like a bumper. So there are these stackable silicone rings that you place on the penis, and they act like penis or whatever device for penetration. They act like a bumper to limit the depth of penetration. So patients who have pain deep in their pelvis during sex my patients have told me that the O-Nut is really helpful. So the website for that is ohnut.co. And they have a fabulous website with pelvic health physical therapists on there too.
You mentioned the hormone changes too. And I know when you're in perimenopause and menopause, estrogen patches are something that people can use. And I know we've talked a lot about breast cancer specifically, but you work with those with a lot of different cancers. So when the estrogen drops, clearly from the sexual health perspective, you've talked about the moisturizer and the lubricant, but what about the other impacts of the hormone changes? Because, the sexual health, which a lot of times is the testosterone levels, what do we do about the hormone part of this?
Where I'm at a large cancer center now, I see a lot of young women who've undergone very intense chemotherapy for leukemia, lymphoma, and then have had bone marrow transplants, which we call stem cell transplants. And they have menopause in their 20s and 30s. And having no estrogen from that early almost certainly leads to osteoporosis and potentially an increased risk of having a heart attack, maybe even dementia. And so it's not just even sexual function, it's like your entire body is impacted. And so the first sign of that is hot flashes, because that's like your body's barometer for where you're at with regards to estrogen. So if patients, so I am a strong advocate for giving them those systemic hormones back. So the easiest way to do that is an estrogen patch, an estradiol patch. There are people out there who are really big advocates for bioidentical hormones, but estradiol as a patch, estradiol is the same molecule as it is bioidentical. It's just, for me, the FDA approved products I feel more comfortable knowing the dose, how everybody processes them, what the blood levels are in patients afterwards. For me, it's a little bit more specific. And I think bioidentical, as a concept, became really popular because for a long time we were giving women Premarin, which was conjugated equine estrogens, which is all these estrogens that aren't even natural to us. Not only that, the companies I'm from South Texas, and I'm a horse person, and those companies there's all these stories about horse abuse, like getting the pregnant horse urine And so our bodies don't really respond very well, understandably, to another species hormones. And so I think that's kind of what was the impetus for this idea of bioidentical hormones. But anything that's estradiol is a bioidentical hormone. Just making it from soy and making it in the lab, like you can't, all the chemicals you give a soybean to make it into estradiol, it's like it's not that natural. So to me, it doesn't really matter. But so I always give patients the estradiol patch and kind of change the dose based on how frequent their hot flashes are. It's crazy. They start to feel so much better. They're like, oh my gosh, I feel like myself again. If women still have their uterus, though, we do need to give them some progesterone back to help decrease, because estrogen by itself, if you have your uterus, can increase the risk of abnormal cells growing in the uterus. So the progesterone kind of is like the brakes on that. And so there's different ways we can do that. Sometimes it's by a pill, sometimes it's through a progesterone IUD. That's kind of where the provider comes in play to kind of make that more specific recommendation. But bottom line is definitely recommend getting estrogen back in some form or fashion for those young patients who don't have an estrogen sensitive cancer. If they still have their uterus, they need progesterone. And if they don't need progesterone. Estrogen hormone replacement therapy gets a bad rap because of a big study that came out called the Women's Health Initiative that was published in 2002 and had two groups looking at women who got estrogen alone and women who got estrogen with progesterone. And the study wasn't even designed to look at breast cancer risk. It was designed to look at cardiac morbidity or the rates of heart attacks with hormone replacement therapy. There are all these issues with the design of the study. But when they first came out, they said that women had an increased risk of breast cancer with hormone replacement therapy. If you do like a deep dive on the data, the estrogen alone patients did not have an increased risk. The progesterone alone patients, progesterone with estrogen, so like the combined hormone, had a tiny bump in their risk. So it might be due to the progesterone and not the estrogen, but nevertheless, everyone associates estrogen with this increased breast cancer risk. So even the long-term data of that WHI trial showed that estrogen alone may actually decrease the risk of breast cancer. But of course, the media didn't pick up that story the same way as it did in the early 2000s when it was like, we're trying to kill women with hormones,
Yes,
so it's complicated.
Yeah, the media definitely sometimes shapes the way we view things, unfortunately.
Yeah.
So can we clarify this nuance with an estrogen sensitive cancer and when you can give estrogen? Because in one, you mentioned that giving estrogen can decrease the rate of cancer, but we know if you have an estrogen sensitive cancer, there's an impact on estrogen. And if you can't get an estrogen patch in that case, then what happens?
It's very confusing.
Yes.
If you don't have a history of estrogen sensitive breast cancer, which really the only ones are estrogen sensitive cancer. So it's breast cancer that's hormone receptor positive or endometrial cancer, which is the lining of the uterus. So those are the big ones that respond to estrogen. And so once you have that type of cancer, we have to be really careful about what we give you, because some things have estrogen properties and can act as like a stimulant to grow. But there's a big difference between systemic hormones, which is like by a pill by mouth or a patch, or vaginal estrogen. Vaginal estrogen works locally. So for even with a woman with a history of estrogen receptor positive breast cancer, I do often prescribe low dose vaginal estrogen, especially if their symptoms of dryness are really severe. And there's no evidence showing that there's increased risk of recurrence for those patients, but it's just a long conversation. But actually it turns out in women without cancer, estrogen may actually be protective. And so it's probably a lot more complicated than we even realize. It has to do with estrogen turning on and off different types of genes and how those genes are regulate cell division for cancer cells versus normal cells. And so we're probably just only understanding the tip of the iceberg for that. But, for women with estrogen receptor positive breast cancer, oftentimes we're blocking estrogen with different medications. And it's important to take those because they're really critical for decreasing the risk of recurrence. And so in that case, we typically don't often give estrogen back by any form because we're trying to block the estrogen. So it's really complicated. And that's oftentimes why, oncologists that I work with, they have a lot to counsel patients on, and it's a very complicated topic. And so that's why I like collaborating with them so I can be like, actually, I looked this up and I think this is actually going to be okay. And, we're always learning.
You have this program and it does seem to be something where you have to collaborate with people, and you've shared so much of what's in your brain. Is there like a packet or something someone could get, or like how could they work with you if they're not in your location?
Yeah. So a lot of what I do is educating other providers in other places, like this is how you treat this so that, everyone gets this information. For those patients seeking this information, I actually, because unfortunately we do have a little bit of a waiting list for this program because my main gig is as a breast surgeon. And so
Right.
I really only am able to do this program on Tuesdays. And so, and the demand is huge. When we offer it, patients come and say that they have these problems because we're asking the questions. So I actually made a free workshop that's posted on the YouTube of my cancer center. It's the Sylvester Comprehensive Cancer Center YouTube page. If you scroll to the bottom, there's a Sex After Cancer workshop, and we have it in both English and Spanish. It's free. It's 2 hours. I talk a little bit about some of the things I talked about today. Pelvic health physical therapist talks about exercises before sex and all kinds of things. We have a social worker who's a doctor in sexology, and so just so much information. And so I can do consults, now with telemedicine being what it is post COVID, just complicated with insurance sometimes.
Right.
So I do have some patients that from other states, and I do a lot of complicated consults, say on patients who have a BRCA mutation. So one thing we didn't talk about was patients who have a BRCA mutation, which is what BRCA, which increases the risk of breast and ovarian cancer. We recommend those patients have their ovaries removed very early, like between 35 and 45. And if they don't have a history of breast cancer, we need to be giving them back estrogen. But a lot of people are afraid to do that because they have an increased risk of breast cancer. And so there's a lot of misinformation out there about how to manage those patients. So I also end up recommending hormones and treating patients who are just at really high risk of breast cancer. And so I end up doing a lot of like complicated consults for those patients as well, because there's a huge unmet need for managing those patients. Like we're preventing terrible cancers, but then are we setting them up for osteoporosis, heart attacks, and dementia by not addressing all these other issues?
Now, what about the part where the sexual desire? I'm sure there's a psychological component, but then there's also the hormonal component. And I'd love to get your thoughts on what people can take away from that aspect as well.
Yeah, so in patients who don't have the estrogen receptor positive breast cancer and endometrial cancer, giving back those hormones really helps with desire. Like it's just making them feel normal again. But it's a little more, and desire really is an androgen-led process. So like testosterone is an androgen. DHEA is an androgen, which is like a precursor to testosterone. So there is, I'm actually about to open a trial looking at vaginal testosterone for patients with a history, even with estrogen receptor positive breast cancer, because probably doesn't impact the amount of estrogen in their bodies. And it can be really helpful for those vulvovaginal symptoms, but also probably helps with desire as well. So that's the hormone side of it.
Yep.
Systemic testosterone for women without a history of cancer is not at this time FDA approved, but there's a lot of off-label ways to prescribe it. And so I think it's, and there's like different bioidentical things that are out there. And so I think it's kind of something we're still studying long-term for safety, especially in high-risk patients. The other big libido conservative measures are exercise. Exercise increases your natural testosterone, and patients are exhausted after cancer treatment. So it's really, I think also an extra motivator to be like, okay, not only are we going to get you in shape and you're going to feel good, but also it helps with desire. And so, high intensity exercise, really getting the heart, no screens in bed. So I talk to patients about sleep hygiene. If you're watching TV and on Instagram in bed, like you're not thinking about sex ever. Sex should really just be for sleep. Bed should be for sleeping and sex only. Little behavioral things that I talk to them about. But then the two pharmaceutical options available to patients, women, that nobody knows about. And there's like 6 forms of Viagra out there on the market, and everyone knows about them. But there's 2 options. Neither one is hormonal. One is called flibanserin, which is a once-a-day pill. The brand name is Addyi, Addyi, and they have a really interesting website. But it's a once-a-day pill. and it works in the brain. It's a serotonin modulator. The only, relative contraindication is patients who, I tell them if they have more than 2 drinks in one day, to not take their pill that day, just to skip the pill, because combining the two can cause low blood pressure and some other side effects. I would say probably anecdotally about half of my patients respond to this medication about 2 months in. It takes a little while, but it is definitely an option. It's non-hormonal and works for some of my patients that with desire, because desire oftentimes, while it is impacted by pain, when I start to fix the pain, sometimes desire comes back. It's also impacted by hormones, but it's complicated, like you said. And then the second option, which I actually have not prescribed in my practice yet, is called bremelanotide or Vyleesi, Vyleesi. It came out, I believe, in 2019, and it's actually an injection that you give yourself before sex. So it's like very interesting, but my cancer patients are subjected to a lot of injections and they are not enthusiastic about this. So they also have a really interesting website to check out, but I have not personally prescribed this yet. I'm glad there's 2 options, and I try to talk about them as much as possible, because the more we talk about this, the more I think industry is going to respond and give women more options.
I always like to say, is there anything that I didn't ask you about that you wanted to make sure you covered?
I just want to, as like a parting message I didn't really touch on, if you're a patient and you're experiencing these issues, even if you don't have cancer and you're experiencing these issues, bring them up to your doctor. And it's nerve-wracking, and you may not get the response you want. Like, you may tell your oncologist and they get really flustered and not really have an answer for you. But if 5 patients that day in their clinic ask them the same question, we want to help. They're going to go home, they're going to call their friends, they're going to look it up online, they're going to come up with the resources so that the next time you ask, they're going to have something for you. And so the big problem with this is that if you ask a lot of doctors, like, oh, my patients never asked me about that, so it must not be a problem. And so I just want to empower everyone to speak up, talk about it like it's normal, ask your doctor more than one time, and eventually more people will come up with the resources to help. And so I just, don't be embarrassed. You have nothing to lose. Especially my cancer patients. Cancer patients have just already gone through so much. Like, I want to just empower everyone to speak up to every doctor that they have. Because, one time I had a patient who had a history of cancer, but also had a history of heart failure. There's a medication we give heart failure patients that blocks testosterone. And she was having low desire. And I said, well, maybe we can switch you from this medication to another type. So I talked to her cardiologist, and he was like, that's not a real problem. No one's ever told me that before. And I was like, well, probably more people are experiencing it than you realize, but bring it up multiple times, and bring it up to all your doctors, and just talk about it normally. And people will come up with solutions for you.
So much of what I say is you've got to talk to your doctor. You have to ask the right questions. You have to be prepared. And I always love to get the different perspectives so that people realize doctors are not robots. They are human beings. And like, we all have a role to play in this very frustrating healthcare system. And, so thank you for that perspective, because it's really, really important. If you could wave your magic wand, what would you love to see change in our healthcare system that would help you do your job better?
Access. I think there are, I work at a very nice cancer center, but you need insurance to see me. And I think that there are a lot of patients who are not insured. And as much as we try to make the public health options equal to private options, they're not. There's delays. Even if you do have insurance, there are delays in getting the care that you need, depending on how proactive you are about insisting on consults and appropriate referrals. And so I think a huge problem is access. And so I don't want to get political on your podcast, but I think that everyone needs to have access to affordable healthcare. And we would prevent chronic illnesses. We would educate patients about how to take better care of themselves. And we wouldn't have so much superfluous spending in the healthcare system if we took the control from reimbursement and gave it to the patients.
Yeah, no, I mean, I completely agree with you. And thank you so much for being honest about it. So let's end on a fun note.
Okay.
What is an interesting fact about yourself?
Oh man, I wasn't expecting to talk about myself at all. Okay. Well, a lot of people don't know this about me, but I used to barrel race when I was younger. So as a teenager, a lot of people don't know about women's Western sports because it's not fancy English sports. But when you go to a rodeo, there's the men's sports, which is like all the exciting stuff like bull riding and calf roping. Then the women's sports was barrel racing, which is barrels in like a cloverleaf pattern. You have to run around them really quickly. It's actually super intense and actually quite dangerous. But I used to barrel race.
Oh, that's wonderful. Now, are you like a champion barrel racer?
I grew up in South Texas, where kind of everyone was a barrel racer, but at some point I was pretty good, and but I wasn't like a state champion or anything like that.
Okay, got it. Nice. Well, thank you so much for sharing. And in all seriousness, I am blown away by this conversation. And I am so, so happy that your team reached out asking to talk about this topic. I mean, it is beyond my expectations. And I'm assuming everyone who listens to this will feel the same way. So thank you for making time. I really, really appreciate it.
Yeah, there's actually one more thing I just want to tell everyone, and that's another amazing resource. We recently put together a program that includes, myself talking about some of these topics, pelvic health physical therapist, other providers talking about pain management at surgery, and you can access that program at wearewomenshealth.com.
Thank you for joining me today on Fempower Health. If you'd like to continue the conversation, please follow me on social media. I am most active on Instagram, LinkedIn, as well as TikTok. You can also subscribe to the weekly newsletter if you want to stay off social media to get the latest and greatest updates. And you can find the link to that either on my website, fempower-health.com, which is a hub to all the different health topics I've covered over the past 5 years, or you can go to the show notes where there's links to all the helpful resources that are relevant to this discussion. And if you know of someone in your life who would benefit from this information, please do pass this along, because that is how we can ensure this important information reaches those who need it most. And for anything that is discussed medically, please understand that none of what we share on Fempower Health is medical advice. It is all for information purposes only, and only a conversation between you and your doctor can give you the care that you need. Thank you very much.